All right. All right. Hello, everybody. Thank you for joining us this afternoon. My name is Jennifer Manganello, and I am a professor at the University at Albany School of Public Health, and I am the moderator for this session. You are in session A this afternoon from 2:30 to 4. We originally had 4 speakers, but currently one of our speakers, the fourth speaker, was unable to attend today. So we will have 3 speakers and then plenty of time for discussion, which is great. So I'm looking forward to hearing the talks. I will introduce each speaker, but then I'll have each speaker give a little bit of a brief overview of who they are to introduce themselves to you, and then they will be going through their presentations. And I think what we'll do is save questions and discussion to the end, since we'll have plenty of time to do that. But if you do have questions or want to put anything in the chat, feel free to do so, and I will be keeping an eye on that. Okay, so our first speaker this afternoon is Molly Hadley. And Molly, if you want to go ahead and introduce yourself, that would be great.
Perfect, thank you. And just to make sure I'm okay, you're not seeing my note slides?
No, I see your cover slide and I see and hear you fine.
Thank you. All right, so I just want to thank everyone for coming today. The title of this presentation is Comparing Experiences and Results of Internet-Based Digital Health Literacy Research. My name is Molly Hadley. A brief background, so I recently completed a Doctor of Public Health degree at the University at Albany, where, at the same time I was working as a health promotion specialist for the university. So, was doing practice-based public health with college students there, also studying public health, and my research interests just kind of aligned with the full-time work that I was doing. And then currently I am out at Colorado College in Colorado Springs, and I serve as the assistant director of the Wellness Resource Center there. All right, so I want to make sure to mention my collaborators on this project: Kimberly Colvin, Mary Gallant, Jennifer Manganello, Philip Massey, Uday Patel, and Tatine Sintel. So a little bit of background before we jump in. Internet-based research has become a popular way to complete survey research and more easily reach priority populations. Meeting participants where they are is a potentially time and cost-saving option for many types of research, and this includes health literacy and digital health literacy research. For example, the internet may be the only way to reach concentrated groups of individuals with certain identities or who are members of unique or rare communities. And then in addition, those who have a condition or a disease that may be stigmatized offline or who have unpopular viewpoints may find more comfort in an online environment. However, internet-based survey research has its drawbacks. So concerning sampling, little is known about the characteristics of an online participant besides their self-reported demographics. Additionally, if you are recruiting participants from an online community, self-selection bias can occur, in which those who opt in to take your survey may be different than those who do not. And finally, the additional anonymity afforded with online surveys can threaten your data quality, as bots or fraudulent survey takers may complete your survey. This has become a major threat to internet-based survey research, especially when an incentive is attached to participation. So when performing internet-based survey research, researchers can choose from different recruitment strategies. One method is online community recruitment. And with this method, strategies vary, but this includes outreach, whether that's through paid social media posts, through email listservs, online newsletters. So any way to try to motivate qualified individuals to take your survey. Another online recruitment method is panel-based recruitment. And this involves hiring a panel vendor like Qualtrics or SurveyMonkey. And in these surveys, users opt in to become panel members and provide their demographic and location information. These panelists are sent opportunities to participate in surveys they qualify for and are compensated for their participation. And on average, they estimate it costs less than $10 per completed survey. Costs may be higher as your eligibility criteria narrows. So previous research comparing online recruitment methods using the same survey exists but have conflicting results. And we could not find research that has been done comparing online survey recruitment methods specifically in the undergraduate student population. So this project compared two cross-sectional samples of undergraduate college students who took the same survey, but were recruited using two different online recruitment methods. So one was community recruitment and one was panel-based recruitment. We will compare the experiences and results across these recruitment modalities. We aim to explain and compare the logistics of each method, including time spent securing the sample, ease of administration, and cost. And then finally, we will compare sample characteristics and key associations with outcome variables. So two samples of college students took the same survey, which was titled COVID-19 and Digital Health Literacy in University Students. This was during the summer of 2020, so just about 2 years ago. The community recruitment survey targeted New York State college students. So this will be study one, and it had a total sample size of 245 students. Community recruitment utilized email listservs and paid social media ads. And then I also wanted to mention the techniques we use to prevent bots or fraudulent survey takers in the New York State sample. So when an interested participant clicked on the hyperlink included in an email or a social media post, they were directed to a screening questionnaire to assess inclusion criteria. If they met the criteria, they were asked to provide a .edu email address. And next, a unique survey link was created for each .edu email address and was sent to that participant and could only be used once. So these techniques were used to prevent bots, fraudulent survey takers, and then to also prevent students from taking it multiple times or passing it on to their buddies. However, and we will talk about this, utilizing these techniques were very time intensive for the research assistant. The panel-based survey, so this will be study two, recruited college students across the entire United States and had a total sample size of 256. They utilized panel-based recruitment through Qualtrics. And sampling quotas were used to ensure the sample was representative of racial, ethnic, and gender diversity in the US college student population. So just a little overview of what the survey looked like. So the title was COVID-19 and Digital Health Literacy in University Students. We had some demographic variables: age, race and ethnicity, gender, whether they were a first generation student or not, and their political affiliation. Then our COVID-19 related questions had to do with what their main information source was, questions around their information seeking behaviors, some COVID-19 perceptions. So we looked at perceived severity, perceived susceptibility, and perceived handling of the pandemic, adherence to different COVID-19 public health guidelines, and then intentions to receive a COVID-19 vaccine. At the time of survey administration, there was no COVID-19 vaccine. Our main predictor variable in this study was digital health literacy. And to determine digital health literacy, we used 12 items from the 21 item digital health literacy instrument. And a few of those items are listed here. The 12 items we used were across 4 subscales. And these subscales had to do with information seeking, determining reliability, determining relevance, and adding self-generated content. And then we also decided to look at health literacy. And to do this, we use the single item health literacy screener, which asks participants, how often do you need help to read instructions, pamphlets, or other written material from your doctor or pharmacy? And now we'll move on to results. So this is comparing the two recruitment methods. along experiences and also cost of both of those studies. So study one, that was the New York-based study that used community recruitment. It was lower cost, so the total cost was $950 plus a full-time research assistant for a few months. It was much more time intensive, and a lot of that had to do with sending out emails, finding email listservs, and putting together social media ads, but also creating those one-time survey links that matched up to participants who met the inclusion criteria. So that was highly time intensive. It did produce a much more homogeneous sample. And then study two, so it was higher cost. This was the panel-based study. The total cost was around $1,500 plus a research assistant. It was less time intensive. So once they had hired Qualtrics, they had given them, the quotas that they needed. Qualtrics took it from there, and they, got the sample size, and the researchers didn't have to do any further work from there. It produced a much more diverse sample that met the diversity of the US college student population, which is what they asked for. Okay, so this chart is showing the results of demographics in both samples, and then two of our predictor variables, so health literacy and digital health literacy. And so you can see that the highlighted demographic variables were statistically significantly different from each other in the two samples. So the sample in study two, that was the panel-based sample, was older and more diverse by race and ethnicity, sex, first-generation status, and political affiliation. And you can see in health literacy, study two reported substantially lower health literacy levels. So about half of the sample was higher health literacy and half was lower. And really the important thing to note here is that the samples were demographically very different from one another. All right, and this chart has a lot, but I'll walk you through it. So on the left side of this chart are some predictor variables that we pulled out. So race, political affiliation, health literacy, and digital health literacy. And then up here at top are some of our key outcome variables. So COVID-19 perceptions, adherence to public health guidelines, and COVID-19 vaccine intentions. So ANOVA and Fisher's exact test were used to test for associations. And if results were similar across both studies, they are highlighted in yellow. So in both studies, you can see that political affiliation was associated with perceived handling of the pandemic. In study two, health literacy was associated with washing hands and wearing masks. However, health literacy was not found to be associated with COVID-19 behavior adherence in study one. And additionally, an association seen in both samples was race being associated with future intentions to receive a COVID-19 vaccine. And when you dug into this data further, we found that African-American students expressed much more vaccine hesitancy in both of the samples. And then most importantly, you can see down at the bottom that digital health literacy was associated with higher adherence to all of the public health guidelines in both studies. And in study two, you can see that digital health literacy, oops, sorry about that, was associated with future vaccine intentions. So in conclusion, with online surveys increasing in popularity, it's important to understand benefits and drawbacks of online recruitment methods. The differences across sample characteristics were statistically significant for each variable except ethnicity, age, and digital health literacy. So these were two fairly different samples of college students, and important findings across both of the surveys were that race and political affiliation and digital health literacy were associated with adherence to COVID-19 public health guidelines. Race was highly associated with vaccine intentions, And an interesting finding was that political affiliation was not associated with vaccine intentions in the undergraduate college student populations we looked at. So to wrap this up, this study demonstrated that 2 modes of online survey recruitment targeting college students were feasible and acceptable when choosing a recruitment modality for an internet-based research study, particularly one focused on digital health literacy or health literacy. It is important to consider time constraints, funding, threats to data quality and integrity, and sample diversity. If funds are limited, community recruitment via email listservs or social media posts is a very reasonable option. However, there's a risk of obtaining a homogeneous sample, and it will take substantially more time to secure a large sample. If the threat this poses to data quality and generalizability is a main concern, using a panel-based study could eliminate some of these challenges. And additionally, digital health literacy may be an important concept to focus on in the college student population to impact health behaviors. And this could be done through modules, added to course curriculums, or through theory-informed interventions. I want to mention a few limitations from this project. So first, it was an online survey. So those with limited digital health literacy might have naturally had a lower likelihood of accessing the survey. It was self-report data, so some social desirability bias or recall bias could have been involved. The sample in study 1 resided in New York State, and New York State had some of the more strict public health mandates, and I think the behaviors were just more normalized in New York State. Digital health literacy, some of the digital health literacy instrument items had a high number of missing values in the New York State sample. And we only compared 2 recruitment methods. So having a sample take a paper version of the survey offline or the addition of another online recruitment method could have created much more valuable comparisons. In addition, these samples were recruited using different sampling frames and methods, thus differing results across demographics, health literacy levels, and associations with outcome variables would be expected. So the distinctive conclusions drawn from each study weren't necessarily in response to the recruitment modality that was used. And that wraps up my presentation. Thank you all very much.
Great, thanks, Molly. We'll go ahead and do a little virtual clap. I'm trying to find, I don't know where my reaction button went. So anyway, thank you so much, Molly. And as I said at the start, for those of you who joined late, our 4th speaker could not attend today. So what we're going to do is have each of our 3 speakers go, and then we will have time for discussion at the end. So our next speaker is Michelle Mavreles Agrodnik. Is that correct, Michelle?
Yeah, that was great. Thank you.
So Michelle will be speaking next. And Michelle, if you want to go ahead and give us a little brief overview about your background and then get started, that would be great. And we can see your slides. Great. Thank you.
Okay, perfect. Thank you. Yeah, so just a little bit of background about me. I recently graduated from Georgia State University with my PhD in public health. My research interests focus around health literacy and health disparities. My previous work around health literacy has focused on working with health profession students, so medical residents, nursing students, respiratory therapists, doing interventions surrounding teaching health literate communication techniques. And more recently, I've been doing some work looking at factors affecting healthcare access among diverse populations with a specific focus on health literacy and within the context of the pandemic. So that's just a little bit about me and what I've been up to. But for today, I'm going to be discussing a study on behalf of my co-authors, Dr. Iris Feinberg and Jamie Bernhardt, entitled Actionability, Understandability, and Quality of COVID-19 Vaccine YouTube Videos, Health Literacy Considerations. So just to get started, I'm going to give a little background and rationale for our project here. So as you may know, vaccine uptake is a global public health goal for containing, preventing, and stopping the transmission of COVID-19. And videos about COVID have flooded the internet and provided individuals with a lot of opportunities to learn about the vaccine's safety, efficacy, and then the need to vaccinate. And so for people to adopt and implement protective practices such as getting the vaccine, it's important that they're able to understand and use health information, meaning information should be delivered in a way that makes it easy for individuals to understand and then actually apply that information. However, during the pandemic, the rush to promote vaccine uptake by improving people's understanding and acceptance of the vaccine led to an abundance of internet-based videos without a lot of attention necessarily to the quality of information being put out there, the use of plain language, as well as health literacy guidelines or visual learning theories. So for the purpose of our research, we examined 2 organizations that engaged in creating and disseminating messaging about COVID-19 vaccines through YouTube videos. And so the first organization we examined was health organizations, which are those that provide information about health, but they don't necessarily provide healthcare services to individuals. So for example, this would be places like the World Health Organization or the Centers for Disease Control and Prevention. And then the second organization we examined was healthcare organizations, which provide services to individuals that have a direct impact on their health. And this could be places such as emergency departments or primary and specialty care places. And so moving forward throughout the presentation, you'll hear me refer to health organizations as HO and healthcare organizations as HCO. So the purpose of our study was to examine the extent to which HOs and HCOs YouTube videos about COVID vaccines used health literacy guidelines and to evaluate the relationship between understandability, actionability, and quality of videos that were created within these 2 different types of organizations, so HOs and HCOs. So we had 3 research questions that we examined. The first was, is there a difference in understandability, actionability, quality, and video length between COVID-19 vaccine videos created by HOs and HCOs? We also looked at what are the relations between understandability, actionability, quality scores, and video length for HO and HCOs individually as well as combined. And then finally, we looked at what is the relative understandability or actionability of a COVID-19 vaccine video that has higher quality scores, and does that differ according to type of organization? So to answer our research questions, we reviewed YouTube videos from May to June of 2021 using the following keywords: COVID vaccine and COVID-19 vaccine. We also used filters, so we only looked at videos that were uploaded at that year, so in 2021 for an actual video and were under 4 minutes in length. And so we decided to look at videos under 4 minutes in length because we wanted to make sure we had enough content to evaluate using our measures, but we also wanted to make sure that we were looking at videos that individuals were more likely to view in their entirety. So we wanted to make sure that the videos were being viewed fully. So that was part of our decision-making process there. And so based on our time frame and our keywords and filters, we selected the first 30 most viewed videos for HOs and HCOs for a total of 60 videos that we examined. So the 60 videos were evaluated using 2 measures. The first was the Global Quality Scoring System, which uses a 5-point scale to measure subjectively online resources about health topics. And so responses range from 1, which indicates poor quality and it's likely unable to be used for patient education, to 5, which indicates excellent quality and is highly useful. And then we also used the Patient Education Materials Assessment tool for evaluating audio-visual formats, or PMAT, to evaluate understandability and actionability. And so PMAT is a 17-question measure, and 12 of the questions focus on understandability, looking at content, word choice and style, organizational layout, and use of visual aids. And then the 5 remaining questions are looking at actionability. So you get 2 scores from the PMAT, your understandability score and an actionability score, which are both reported as percentages. And the higher the score, the more understandable or actionable that video or material would be. So for our methods, we had 2 researchers score each of the 60 videos using both the PMAT and the GQS, and then inter-rater reliability was evaluated between the 2 researchers and substantial agreement was found for both measures. So for our results, that's a reminder, research question 1 was, is there a difference in understandability, actionability, quality, and video length between COVID-19 vaccine videos created by HOs and HCOs? And what we found was that there was no reported differences in values between the organizations for actionability, understandability, or quality. However, video length for HCOs was longer than for HOs, and a Mann-Whitney test indicated that this difference was statistically significant. For research question 2, which was what are the relations between an average understandability, actionability, quality scores, and video length for health and healthcare organizations individually as well as combined. We looked at Pearson correlations, and what we found was that there was a significant relationship between understandability and quality, actionability and quality, and understandability and video length among HOs and HCOs combined. However, when just looking at HOs, there was a significant relationship with actionability and quality and actionability and video length. And then just looking at HCOs, there was a significant relationship between understandability and quality only. And so for our final research question, which was, what is the relative understandability or actionability of a COVID-19 vaccine video that has higher quality scores? And does it differ according to type of organization? An odds ratio analysis was performed, and it was found that HO videos with higher quality had higher actionability scores, and healthcare organizations that had higher quality videos had higher understandability scores. So we found that there was a wide range of use of health literacy guidelines by HOs and HCOs, and there's also a relationship between quality of COVID-19 vaccine YouTube videos and either understandability or actionability, depending on the type of organization that was delivering the message. Overall, HOs and HCOs can take steps to improve the quality and understandability and actionability of the videos they produce by using more evidence-based health literacy and plain language principles. And using these principles can help to ensure that information is easily identifiable and understandable. And so in our study, videos that received the highest understandability scores had a clear purpose, presented information in a logical order, and chunked information together that made sense and was easy to follow. And the videos that received the highest actionability scores actually addressed the audience directly and presented at least one action the audience could perform with explicit instructions on what steps they should take to do the action. And so by using these features, the videos may have been more clear and easier to understand. And so HOs and HCOs can incorporate these existing tools in their organizational health literacy plans to ensure the most effective and health literate video messaging. And then there were a few limitations to this study worth noting. So first, the number of videos were limited to the first 60 viewed videos. While this does limit the generalizability of the findings, actual video searching patterns show that people typically don't look past the first couple pages of searching. So this may be more of a practical methodology used that would apply to actually how people are looking at information. Second, the measures that we used, the PMAT and GQS, they required subjective evaluation. And then finally, while the dissemination of video-based, high quality, actionable, and understandable information regarding COVID vaccines may play a role in educating health consumers, there are definitely other factors that need to be considered that can influence vaccination practices, such as culture, social stigma, economics, and the politicization of messaging that was going on during the pandemic. So those could also play a significant role in vaccine understanding. So thank you so much for your time. And this is just my contact information, as well as the principal investigator, Dr. Iris Feinberg's information, if anyone has any questions that they'd later like to reach out to about. So thank you.
Great. Thank you so much, Michelle. That was great. And for our third and final speaker today, we have Mackenzie Carter. And I'm going to go change the pin down so we can see her. Let's see.
Okay, all right. Is the presentation visible for everybody there?
Yes, I'm seeing it with the notes open though.
Oh no.
And we can hear you well.
Oh, that's good. That is good. Well, let's see. I do not want you guys to see my notes. Apologies, folks. I thought this far into the pandemic, I would have figured this all out, but let's see. See all slides. If anybody has
I
any
think if you go to display settings,
okay.
there you go. Yeah.
Oh, beautiful. Thank you so much, Michelle.
Great. Looks great. Okay, thanks.
All right. So good afternoon. My name is Mackenzie Carter. I recently graduated with my MPH and a graduate certificate in rural and community health. I work for a local health department, Kittitas County Public Health in Washington State. I work on a number of different programs, one of which has been and continues to be COVID-19 vaccine outreach and planning. So today's topic is exploring the relationship between the number of COVID-19 information sources utilized and the likeliness of receiving a COVID-19 vaccine in an unvaccinated rural population. So we know that a lot of adults worldwide use social media. That's not new information. As of 2021, approximately 38% of the world used social media in some form. Public health, we have tried very hard to harness that power for good rather than the forces of evil, but that is so much easier said than done. So COVID-19 threw us all a curveball as we work to try to share the most accurate information available to us in an accessible, equitable way. So we've had to have more conversations and more, I call them brain benders, where we're trying to figure out what to do to help people and to get across the information we need to. So misinformation is continuing to circulate around COVID-19, from disease myths to different vaccine safety falsehoods. And these have popped up on Facebook, Twitter, and TikTok, as well as in more traditional formats, such as in newspapers, on the radio, and on television. Throughout COVID-19, residents of rural areas have had higher COVID-19 case counts, hospitalization and mortality rates, and lower immunization rates than their urban counterparts. Rural residents are more likely to be conservative politically, which often coincides with reduced adherence to COVID-19 safety measures, such as social distancing, mask wearing, and COVID-19 immunization. So low health literacy mirrors a lot of the characteristics that we see in individuals who are vaccine inquisitive or vaccine hesitant. That includes lower socioeconomic status and education levels, residents of rural areas, individuals who do not have a chronic health condition, non-Hispanic whites, and again, conservative individuals. And that is a very, very general overview. We know that it's a much more complex issue than that, but just for the sake of this, those are some of the little highlights. So we've looked, research has looked at the different effects of COVID-19 disinformation and misinformation on numerous aspects of the virus and the vaccination rates, such as lower vaccination adoption in areas saturated with that false information, and decreased COVID-19 safety precautions along compared to TV network subscribers. And people with access to better health resources are more likely to choose a healthy behavior. That's not to say that just the people who aren't making the quote unquote healthy choice don't have access to information. Sometimes people will still choose to do something different. But if you don't know, then you don't necessarily have that opportunity to look at some of your options. So a little background on the location. Here highlighted in red is Kittitas County, where I live and work. It is in the geographical center of Washington State. And as of the 2020 census, we have approximately 45,000 people. And then during the academic school year, we also have an additional approximately 10,000 students, thanks to our large public university. It is classified as a rural county by most government agencies, but we are adjacent to two large metropolitan areas, one of which is Seattle, there to the west in King County, and to the south down in Yakima County. And though it is geographically one of the largest counties in the state, we're fairly sparsely populated with only about 19 people per square mile. Okay, so in this research, we wanted to look at is the likelihood of unvaccinated respondents to our survey to get the COVID-19 vaccine in the future influenced by the number of sources used to receive vaccine information. So in September and October of 2021, the Kittitas County Public Health Department administered this Kittitas County COVID-19 Vaccine Community Survey to all residents of the county, ages 18 and older. It asked questions about general COVID safety, whether they had received the vaccine or had not. And it also asked questions about general demographics as pertaining to the survey questions. It was administered in both English and Spanish. And we did receive about 1,600 total responses, and not many of which were not kept because of profanities or just straight nonsense, or garbledy-gook, as I like to say. So we wanted to look at why people had received the vaccine or why they had not. What were their concerns about getting it? And for reference, as of last week, the county itself is at a 54% primary COVID-19 vaccine completion rate. That has not changed much since the survey was administered last year. We've gone up maybe 1 or 2 percentage points. This is in a big contrast to Washington State as a whole, which prided itself on being one of the first states to reach a pretty high percentage. It's at about 74.4% age 5 and older being completed. So again, kind of that influence of Seattle, the folks on the western side of the state having much higher rates. Obviously, we have a big drop, so we wanted to understand why. So in order to categorize the different quantities of information sources, we used Blanche Hartigan et al., which looked at a similar concept with quantity of information sources, and they grouped it by 5 or fewer information sources and over 5. So we used the Fisher's exact test to examine if the number of sources used increased the likelihood of unvaccinated respondents, which for the study from that 1,600 pared down to about 330 to get a COVID-19 vaccine in the future. So here on the left, if a respondent answered that they had not yet received a COVID-19 vaccine, we asked, how likely are you to get it in the future? And then using that Likert scale, we had 0 responses of very likely or likely. All of these unvaccinated individuals responded either neither likely nor unlikely, unlikely, or very unlikely. And then for comparison here on the right, we asked of all survey respondents, regardless of vaccination status, what are the top ways you get information about vaccines for yourself and or your family? Select all that apply. So they had, I believe, 19 different sources to choose from. We did debate within the department whether we wanted people to rank or to select only their top 3, which in retrospect, we wish we had done, because some people chose about 10 and it made it very interesting. But as we'll see later on, that was the case for some people. So for that sample of 330 individuals who were unvaccinated and examined in this study, the majority of those individuals were female, aged 35 to 44. They were white, not Hispanic, had a bachelor's degree education, and then despite that, though, had only about a $20,000 to $29,000 income, which is a bit of a discrepancy, and we're not sure exactly where that came from. Typically, if you'd have a bachelor's degree, you'd have a slightly higher. But this demographic information aligns with a lot of our department's Facebook page, which is where the majority of survey respondents stated that they learned about and took the survey from. So it was kind of interesting because typically I do think we have some hecklers who subscribe to our page and just follow it so they can post nasty comments. But the majority of people who follow us on Facebook and engage with us on social media do fit this demographic profile. And Kittitas County is not a very diverse area. Only about 10% of the population is something other than a non-Hispanic white individual. So these numbers matched pretty well with both the overall demographics for our area as well as for the survey as a whole. Okay, so we looked at here those answers to the Likert scale question about their likeliness to vaccinate in the future. As you can see here, most people were very unlikely. This was a common thread throughout the theme. People who were not vaccinated did not plan on it at all later Very little said they were neither likely or unlikely, handful unlikely, but the majority here, which tracks. And then for the Fisher's exact test, we again kind of categorizing by that 5 or fewer sources or greater than 5 sources. There was not a significant p-value. So there was not a correlation or statistically significant one for the number of health information sources with their likelihood of getting vaccinated for COVID-19 in the future. So additionally, we can say that we can fail to reject the null hypothesis, and we looked at whether there were any differences in the sources for these 3 categories. For the sake of time, I'm just going to go over this overall one. So the top 3 information sources for the overall unvaccinated respondents were a doctor, nurse, or clinic. Here is the #1 source of information, which for me was quite surprising, followed by internet websites and the CDC. And I will say, I thought it was very fascinating that both vaccinated and unvaccinated respondents cited a doctor, nurse, or clinic as their #1 source of information. So I'm just going to pass over those. So overall conclusion is that the number of health information sources used did not impact the decision to get a vaccine in the future. We did have a small sample size of unvaccinated respondents, and also that second most used source of internet websites is a little bit vague. Does that mean Fox News? Does that mean a blog? It's pretty vague, so it's hard to tell if what that means exactly. And what we wanted to look at in the future was the quantity versus the quality of information sources. So, if they're citing all government websites, but there are a lot of them, does that make it less or more valid? And it gets into a little bit of subjectivity versus objectivity for the information sources. But we would love to look at that in the future. Here are resources, and that's my presentation. Thank you.
Great, thank you, Mackenzie. And I forgot to do clapping for Michelle, so let's clap for both Michelle and Mackenzie. Nice work. So thanks to our 3 presenters, and we'll have some time for discussion now. And I was going to start off with a question that was asked in the Q&A earlier. Someone had asked a question about, what do you do for bots when you're doing online surveys? And I know this is something that people have really been struggling with. And I heard recently now with AI out there, I don't know, I don't really get how it works, but they just can go through the whole survey and they keep doing it till they figure out the pattern. So there were a few things that we did in ours. Mackenzie, you might have some input as well. And Molly, I'll mention a couple of things, and then the 2 of you could jump in also. And I'm also going to post a link to a resource at UCLA that has some ideas. But one thing I always use is eligibility criteria at the start. So there's some specific questions there. And if they're not answered the right way, the person gets kicked out of the survey. And sometimes I'll make one of those open-ended so that it's a little bit tougher, for someone to get through that first part. I also will check for IP addresses to see if there's multiple surveys coming from the same IP address. And then I'll also usually have an attention check where, I think the survey I just did this summer, I had a question like, mark often for this question or something. And so we can then go back and pull out the ones who didn't mark that. People have often suggested using CAPTCHA, although I hear that that's not really working as well lately. And then, you can also try using a personal link that's only valid for one-time use. But to do that, that's really tough. It works actually, Molly, maybe you can speak to that, because it works when you're doing community-based recruitment and you're recruiting someone one by one and you have a specific process for that. But especially with these panel surveys, you don't have that kind ability to do a personal link. So maybe Molly, do you want to jump in, and then Mackenzie can add any other thoughts too?
Yeah, I mean, the personal link worked really well for our study. Additionally, we were lucky because .edu email addresses, you really can't just create one of those. So the fact that we are using college students for our study helped us. It was a ton of time though to, they would see our advertisement, they would click on a link, it would assess their inclusion criteria. And then if they met that criteria, it would send me an email, but then I would have to reach back out to them to give them a survey link. So we also lost a lot of people who then didn't click on the survey link. So it's not a perfect way to do it. And I just wanted to note that, through this study, I tried to look through the literature on what to do with fraudulent survey takers or bots that are suspected. And they're really recommending you remove any suspicious survey. And there was a good example of the results of a research project pre-removing those surveys and post. And the outcomes were completely different once they had removed those fraudulent survey takers. So yeah, it's definitely an important thing to screen for and to really look into when you're doing internet-based survey research.
Yeah, the only thing I would add, so we used SurveyMonkey for our survey, and I was warned by several professors, like, oh, don't get so excited about all your responses. Many of them are probably bots. We got really fortunate that only about 200 of them were kicked out of that 1,600 we received. But I think we did limit it to one IP address, which was great for catching that, but we did run into issues from an equity standpoint where we had two fantastic promotoras going out into the community and recruiting Spanish-speaking individuals, but they couldn't then take, a Surface Book or an iPad and let multiple people take it with them because it's limit one per IP address. So it was that balance. We made the call in this situation to limit it to only one IP, but then we may have missed out on some of those other opportunities for some of those underrepresented voices. So that was our main tactic. We have since switched to Qualtrics, and I think there are some better features built into that to help avoid bots, but I have not played with them yet. So I'm curious to see if that has much impact or not.
Well, and I think one of the issues too is how do you decide which cases to throw out? And so that was part of our thing. So the survey I did this summer, we had some that didn't seem like bots based on the different screening things we did. But then they had some just random garble stuff in an open-ended question at the end. And, we were like, well, is that random, or did someone just type some letters because they thought they had to get through that window? So it can be tough as making these decisions also. And Mackenzie, Michael put a note in the chat too. You had mentioned something about hecklers, which I'm sure you get with the vaccine surveys, but can you talk about that and how did you deal with that? And
Yeah.
Lynn's also asking you a question about that. Yeah.
Yeah. So, and I did my thesis project as well using the data from this survey. So I got to look through it twice, see all of the lovely comments and for the open-ended questions. We asked, it was mostly on some those short answer questions asking like, what would make you feel more comfortable getting the vaccine, and just a lot of, some of it was just curt, like nothing, absolutely nothing will change my mind, which did not get filtered out or kicked out as garbledy-gook, but it was it was a fine line. Like you said, is this just nonsense from a person, a real life person, or is this a bot? So I had to make a call of, is saying something offensive enough to kick out the response if they have other meaningful things to say? And also I can take somebody calling me a traitor to the country and to every person in the county for offering things. But I can't, Lynn asked, I think 2 questions to answer what proportion of your responses were that. I'd say maybe 5%. It was a very minimal amount, but some of the stuff, fortunately, I started working at the department in June of 2021. So I was a little bit not as sensitive to some of the comments that were being made, but I know that like our director and our assessment coordinator, there were some really hurtful things shared in there. So I'm not sure if I answered the questions. Hecklers mostly just being just blatantly rude in their responses, but then we also had funny things like their gender identity was purple dinosaur space cowboy. So it's a balance.
And I wanted to get back to another question earlier that someone had asked about the information sources. Inga asked a question about whether there's a valid and reliable question to assess source of health information. And Inga, this is something I always struggle with too. I mean, I've been asking on a lot of my recent surveys about health information sources, and I would love for there to be a more validated scale of health information seeking. One of the things I typically do is I'll look at questions from the HINT survey, which is out of NCI, and I will put a link to that because they've been working on a lot of questionnaire, survey design around health communication for a while now. So I will often check there, and then I, will look to literature to see if there's a particular scale, but otherwise I just have a set of questions I've been using about what, the sources you most often use, which sources you trust, etc. I don't know, Mackenzie or anyone else, do you have thoughts on whether you've used any kind of validated health information source scale?
We chose to focus more on the number of sources, but it did pique my curiosity as to whether that was something like the quality of them. And it became less an issue of having a validated tool and more of a, with COVID changing the parameters so quickly in response to things, I found, and especially in this survey responses in September and October of 2021, where things were picking back up again, that is like the CDC might not be valid at every moment because it can't always keep up. So it's hard to say that even like a government source or my own department's website is consistently valid. And so I don't know if I've come across any instrument that takes that into account of the rapid changes potentially with infectious diseases. I feel most of them are looking at it from like longevity, or not longevity, like as a whole rather than as a moment in time, if that makes sense.
I'm going to just pose a question to Michelle, just so that we're not leaving Michelle out of the conversation. Michelle, I thought it was really interesting that you found in your videos that the health organizations were more action oriented and the healthcare organizations had a greater understandability rating. Is that what did I interpret your results correctly?
Yeah, the health organizations had higher quality videos and actionability scores.
So one question I had was why you think that is. And then the other thing I just wanted to mention is that a lot of times when I do my trainings, I talk about the 3 A's of health communication, which is that health information should be accurate, accessible, and actionable. So I'll just put a link to that in the chat for people who are interested. And so I'm curious, why you think there was this difference between the 2 types of organizations, and how do you think that you could potentially get, you had some recommendations at the end. So what are your thoughts about how you could potentially get recommendations to these organizations about how to present health information?
Yeah, so looking at the 2 different organizations, so like the health organizations versus the healthcare organizations, the health organizations which provide information, but not necessarily help with like providing direct services, I thought it kind of made sense that those would have higher understandability scores, because they're more likely to be trying to give the population information versus healthcare organizations who are directly trying to work with people to take steps and do actionable things. So I thought that kind of aligned well there. Um, and then I'm sorry, what was the second part of your question?
Just how do you think that, given that there are recommendations about how to present information and that we might want to have both, have it be understandable and have specific action items, what are some ways that you could potentially get recommendations, do you think, to organizations about how to present their information in a more comprehensive way?
I think looking at like from a health literacy organization perspective, I think going at it from that angle and working with organizations that way to incorporate different strategies and techniques could be something that could help to make the messaging clearer and more accessible. And I kind of had a question related to the other studies when thinking about fraudulent responses and whatnot. I was curious, did you guys look at duration as far as your participants and how long they took to get through the survey to like look at bots that way?
I've done that before with some of my surveys, and definitely it's like if someone went through it in like 45 seconds. That's another criteria that I have used. I don't know, Molly, Mackenzie, did you look at those?
We didn't, just because we thought we had it so locked down on that one-time survey attached to their .edu, but Jen and I have worked together on this, looking at a digital health literacy intervention. And yeah, I think we had me take it very quickly. And then where I didn't even really read the questions, it was like I scanned through and took it. And anyone less than that, we were really skeptical of. Even if they are a real survey taker, they're likely not reading the questions, but just doing it for the incentive, which is tough.
That is frustrating. The surveys that we've had where we offered incentives, we had that surge of bots. This one we didn't offer, mostly because our overseen body does not like incentives. So, but we didn't look at the time. I know it captured it and spit it out into our spreadsheet, but most of the other people that we felt were not real or not really answering any, like you said, they're, even if they are a real person, they're not really actually contributing anything. So we didn't end up needing that data point. I did do that a little bit for my thesis responses, but not for this overall one for the department.
Mackenzie, how did you get that many people to take your survey without an incentive?
People were angry. We realized pretty quickly that this was a platform that people were using to vent and to express some of their frustrations, which was the purpose to a certain degree. We were not expecting that many. We needed, I believe, 382 responses in order to be significant for our population. And then it just kept climbing up and up and up. And it was, to the best of my knowledge, it was that, yeah, people were just angry, or angry not even with us, but just angry with their community or the other people around them. And they wanted to express that frustration.
Gary has a question in the chat about what our thoughts are on best practices for the number of survey questions and or length of time. I know I typically go by length of time, and I basically decide that based on whether I have an incentive or not and what my incentive is. So because you're not going to get anyone to do like a 30-minute survey without an incentive. So I don't know, Molly, how long was the survey and that study? I can't remember.
Yeah, we estimated 15 minutes. But Gary, this is an important question because in my presentation, I mentioned that we had 3 items in our digital health literacy instrument that didn't get a lot of responses, and that's because it was further down in the survey. So we kind of broke them up by category in the survey, and the 3 items that were the furthest down, we had a lot of missing responses because they just stopped taking the survey at some point. So maybe 10 minutes is the sweet spot. It's a really good question though, because it's hard to get a lot into 10 minutes.
Ours ended up being about, I think, 4 to 6 minutes. We had additional questions if a person responded that they were a parent or guardian for a child under 17 or younger. So those who didn't have that had a shorter survey time. But that really is a fantastic question, because how do you not fatigue somebody? And also, I think it also depends on the types of questions. If you're only asking Likert scale, I know my eyes start to glaze over after a couple in a row, one after the other. So that variation, as much as the survey and content allows, I think also helps break it up. So yeah, it's a tough balance. I had a question for Michelle, actually, if that's okay.
Great.
You mentioned one of the criteria for your filtering of the videos was that 4-minute mark. Was that something that you guys had encountered or were working off of as like that's people's attention span, or was there other rationale for that criteria?
Yeah. So doing a little bit of like literature review and informational searching on that, we found that that was about the around the time that people started to disengage in the videos. They might only watch like the first couple minutes of it. Then when you reach 4 minutes, you have more of an engagement drop. So we were trying to have go for the maximum engagement in the videos and try to capture that. So that's why we went with that 1-minute mark.
Other questions from the group? Michelle, what did you do if there were there any duplicate? So you said you did 2 different groups of organizations. Were there any like duplicate videos that popped up, or did you have a pretty clear sense of which organization was falling into which category?
Yeah, we had a pretty good sense of which organizations were falling into each category. So there weren't any duplicates in the groups. It was just the 30 top most viewed for each, the healthcare organizations and the health organizations. And then we just evaluated all 30 from each group.
Okay, great. Any other questions from the group?
I have this kind of concern about this like sources of information thing. When I
Yeah.
talk to my kids, sometimes they go to sources for entertainment or like because they think they're outrageous.
Yeah.
Now, that doesn't mean they're not affected by those sources, but it's different than like, what do you think is, authoritative or, or reasonable? I don't know, anyway, I don't know if you have comments about this.
My only comments would be personal based on what my tweenage son watches on YouTube. And yeah, it's funny because he goes to different videos or these different, accounts based on they're funny or whatever. But then, he watches them on our TV. So I'll see what he's doing or watching. And sometimes he actually does learn some good information. But that wouldn't be considered like a health information source, right? So it's a good point. And I'm teaching my media and health undergrad course this semester, and we talk a lot about that, like, the difference between intentional information seeking versus passive information seeking, right? So I specifically want to know about, sore throat symptoms and I'm going to search for that in Google versus I happen to be watching something and they talk about sore throats or some virus that's going around. So they are different. And we actually did my survey this summer that we did ask about, we had some questions trying to distinguish that active versus passive health information seeking, but we're just getting to the analysis now. So we'll see. I don't know, Michelle, do you have thoughts about the YouTube videos that you saw? I mean, are those, they had a high number of views, right? You picked the ones based on a high number of views. Do you think those are videos that people just came across and saw, or things that people would have found in a search?
I think some of them could have been both. I think if someone was searching for information about the vaccines, these would have been what would come up. But some of them were also like, they looked like ones you would see on TV. So like if you were just watching TV, you might passively see this video as an ad. So yeah, I think it could have definitely be both.
I think one of the crazy things in this space is that the rules have changed even from a couple of years ago. And so if you ask someone, do they trust this source of information? In a way, it's all actually backwards. Has the algorithm correctly identified something that it believes that you already believe? And so since so many people are kind of in like an echo chamber from the algorithm selected sources for you, do you trust the information kind of means, is it concordant with other things that already learned that you believe in? Which is the opposite of kind of, I searched this thing and I trust because I like it. It's it's kind of a measure of how accurate is the algorithm.
I think that raises a great point. There's a comment in the chat about the news sources like Reddit and Twitch. It's that confirmation bias. You subscribe to these communities that you already believe in, and whether or not it's true, a lot of times, like they said, these streamers and online people are just summarizing their own version of that. So that's, again, another part of why it's so challenging, like from my perspective, to qualify something like Facebook, because you have nuggets of truth. You have something that may have like stemmed from a truth or a partial truth, but then it just becomes warped and, like you said, kind of diverted into these little pockets where you're already visiting. So it's kind of a weird passive and active search for information. I do wish that we had phrased the information source question a little bit differently, not only to rank and rate, or rank or rate, but we just asked what are the top ways you get information rather than what are your trusted sources, because that implies a top ways is like maybe you are just scrolling on Reddit or Facebook and you come across something. That doesn't mean that you do trust it or that you should trust it. So
there's this question from Inga about the 4-minute.
Yeah, Michelle, did you see that? Was there a reason that you selected the 4-minute criteria?
We did like a literature search and found just information regarding participant engagement in videos. And there were a few articles that we found suggesting that the longer the video, like a certain cutoff, the engagement drops and declines.
Yeah, Michelle, that's consistent with what I've seen too, that videos really longer than like 3 to 4 minutes, people aren't going to watch the whole thing. So
Even at that length, it has to be a fantastic video.
yes, yes.
Right.
It does. Well, because, everyone's used to watching like 15-second TikToks. And so, if it's, and believe me, I've seen some amazing TikTok videos where health professionals are providing really excellent information in 15 to 30 seconds in a very entertaining way. So if then someone goes over to YouTube and they're like, oh, here's this 20-minute snooze fest from my local health department, it's tough to compete. So you know, that's one of the things is we've got to get our messaging where people are in a way that they are paying attention to, but it's tough because a lot of us don't have time to be, you know, TikTok superstars. So I don't know what the answer is.
I've made a lot of videos in the range of 3 to 5 minutes, like hundreds in different languages. And the only way that they work is that we actually have like the patient and the social worker are sitting together to watch them. So then it would be like extremely rude to say, no, I'm done. I'm going to get up and walk away because they were sitting together, or like a community health worker or something. But even then, it's, you know, the doctors won't sit through 3 minutes.
Yeah, that's right. That's right. And actually, when I look for videos that I use in my trainings, I get, you know, or my classes, I look for things that are, you know, 2 to 3 minutes, because I know everyone's going to kind of doze off after a little bit. So, yeah, so it's an interesting dilemma. Anything else?
Yeah, just to add on to all this, I think with how hard and confusing it is to think through health information sources and trying to motivate people to go to reliable sources is thinking through digital health literacy and kind of trying to use more just a kind of demographic characteristic to predict what information source they're using and believing. And in this same survey, we found that having higher digital health literacy only predicted using one source as a main source of COVID information, and that was government agency websites, which was probably our most, you know, reliable, credible source that we listed in that list. So I think that's the exciting thing with digital health literacy. If we can improve that in populations, hopefully they'll be able to use and, I don't know, believe credible sources, or just go to that as a first place to get their health information.
Even when they respond though, Molly, there's some of those people are giving you the answer that you want. They know they're supposed to just say government sources, even if they enjoy some other things at times.
That's true.
But the other thing that's so interesting is, again, teach in this undergraduate class, I had a student come in and she was, you know, talking about edutainment and learning about health and TV shows. And she was shocked when she asked the class, you know, there's like 25 students, you know, who had something about Grey's Anatomy, and not one person had ever watched that show. And in fact, a lot of the students in the class say that they never watch TV. And there's actually a few students who actually don't use social media at all. And so I think the other thing to always remember too is with this information sourcing and information seeking is sometimes we think we might know where an audience is getting their information, but it's sometimes we're surprised. I mean, I've had a lot of surprises this semester when they talk to me about where they're getting information. So that's why it's also so important to know our target audience and to make sure we talk with them and figure out what sources do they trust, or what sources are they going to be exposed to, or we might not get our message out in the place that they're going to see it.
Mandatory. I don't know if Tom, you can tell us more about how that works.
Yeah, Tom, that would be great.
I think we'd have to have Tom raise your.
Oh, yes. Let me see. Do I have to unmute Tom? I don't know if I can do that. No,
I think we're not.
I don't think I can do that. Well, that's it. I think I know it, but so Tom, it's supposed to be the kind of thing where you can't even get. Oh, here he goes. Let me see if I can.
Did I get it?
Yeah.
Yeah. Good. Okay.
Sorry. So we have that program, and I think a lot of other hospitals, at least a few major hospital chains have it, but VA Portland has a program called the Get Well Network, which is a pretty common one. There's a lot of different tools within. I am literally just getting my feet wet on it as the local coordinator as of a week. So, but I've been part of at least part of the planning process for rolling out contractually. But ultimately, there's videos that we can assign that are mandatory. We kept it to a minimum because there's a number of complaints. Our veterans are not hesitant to express their concerns, or if they want to do something else, then watch it. But I've already assigned them 2 different videos. One is a call don't fall video. So it's like we made our own local program based on our own interventions on what kind of fall prevention strategies we want. This is for things like, I don't know, wear your traction socks and call the nurse before you get out of bed, and make sure you have your walker with you, whatever it is. And then we have a healthcare advocacy video, like it's okay to ask your nurse to wash their hands. If you didn't see them do it, they'll be happy to do it again. Ask your doctors if you don't understand things. Don't sign an informed consent if you don't actually understand it. Those kinds of things. And so those are the only 2. And then we have so that before you can even get to your television are mandatory watching. So everybody has to watch those. And then the nurse can go through and assign programs to people. And that's going to be kind of our next rollout point, is going to be, I don't know, let's say if you're in for CHF or something like that, we can assign ones before the next time. Within the next 4 hours, you need to watch this video, or you're basically not going to be able to use the television. I think the nurses can ultimately turn it off. So if it's somebody's really going to be unhappy about it, it may not be worth the stress that goes along with having somebody be upset that they have to watch a video about their new diagnosis for congestive heart failure. But these are all like kind of professionally made videos, usually fairly short, kind of around that kind of 4-minute time that we're talking about, which is kind of where people are going to stop anyway, or just going to get too long where they're going to turn it on, turn the volume off, like we do with, like we find with a lot of our other mandatory trainings for even our own hospital staff. So try to find that. So I think it's just a good way to kind of get these people that are already in the hospital. They're already in a new environment, and it's good. It's a good way to be able to capture them, but also it's how are we going to engage the nurses to sell this idea also? Are there other ways that they could turn it on? Like I had the number of explanations as a nurse that I had to have as soon as the doctor walks out the door of, they're like, oh, the person's like, oh, I guess I have a new heart thing and I just need to take one more pill, when they have congestive heart failure. And it's not just a pill. It's a lot more complicated than that. And having those actual explanations with them as a nurse, but then I still have 5 other patients I need to go care for. So maybe I can just start with the television show, do something digital, and then come back and how did that work for you? Does it make any more sense? Do we need to have the congestive heart failure navigator come and talk to you? And just, I know people learn in a lot of different ways and with a lot of different functions, and hearing it 5 times from 5 different directions may do better than one really good source. At least that's what I found personally.
Yeah, that's a great point, Tom. Definitely getting information from multiple sources and repeating it is never a bad thing. I know I've learned that just from things I've done. So great ideas. Well, we're almost at 4 o'clock. And so thanks for such a great discussion. I really enjoyed it. And I really enjoyed all of the presentations. So if you do want to save the chat for some of the resources, you should be able to do that by going to the lower right. There's 3 dots. And if you click on those, it says save chat. And otherwise, I hope everyone enjoys the rest of the conference. And thanks again for joining us this afternoon. Have a great day. Bye, everyone.